previous section on webinars that is recorded there. So I will hand over to Professor Jeff Choi, who is a staff at the Cleveland Clinic when I joined as a fellow almost 10 to 13 years ago. He will talk a little bit about what is the topic that we're going to discuss today before handing over to Dr. Calvin Chen to introduce our speaker. Thanks, Prof. Choi.
Thank you, Dr. Tien. So it's my great pleasure to be here to join all of you to have this webinar section, and we will welcome Dr. Bojani to give us a talk about this new laser. So it's been a while, you know, it's been about 30 years since I finished my residency. At that time, you know, we all think, you know, the TERP, monopolar TERP is the gold standard. But as time goes by, when we have the bipolar TERP, well, it's like much safer. You get rid of the water intoxication. Seems, you know, that's already the platinum standard. But then you have the other HOLAP, holmium, and thulium, and now we have this salted laser. So I'm very excited to, you know, learn more about this new laser energy, and to see especially what would be the you know, the difference between the other types of laser, and what's the advantage, what's the pitfall, the you know, the tip and tricks of using this laser. So I'm very excited to be here and happy to, you know, join this activity webinar to be held you know, by the Asian School of Urology. So without further ado, I will give this podium to Dr. Calvin Chen, to introduce Dr. Bojani from University of Montreal, Canada.
Thank you, Prof. Choi, Prof. Tiong. It gives me great honor and pleasure to welcome Dr. Bojani. So Dr. Naeem Bojani was born and raised in Montreal. He obtained his Bachelor of Science in Microbiology and Immunology, and another in Physiotherapy from McGill University in 2001. And then he completed medical school and urology residency at the University of Montreal. In 2011, Dr. Bojani spent 2 years with Dr. Lingerman at Indiana University, completing his fellowship in BPH and stone disease. He was then recruited by the University of Montreal in 2013 to build and develop comprehensive kidney stone and BPH programs. At the University of Montreal, he has a rank of associate professor and clinical researcher. It goes without saying that Dr. Bojani has published extensively in stone disease and BPH, and is an editorial board member of the Journal of Urology. Dr. Bojani in 2017 was also named the AUA's Young Urologist of the Year. And in 2019, Dr. Bojani was awarded the prestigious Clinical Research Scholar Award from the Quebec Research Funds. Now, this is Dr. Bojani's bio, but you know, as a person, our short meetup in November last year, he's actually a very nice, kind, and approachable person. So it gives really great pleasure for me to welcome him to give his talk on SOLAP, how I do it. Over to you, Dr. Bojani.
Wonderful. Thank you, Calvin. Thank you to the Asian School of Urology. Thank you to the deputies, directors. My pleasure to be here. I appreciate the invitation. It's my honor to present on SOLAP, how I do it. So we're going to go through my slides, and the plan is about 30 to 40 minutes. And then we'll have a good 20 minutes for your questions. So if you have questions, I think there might be a chat box that you can write them in, and then I'll be happy to answer them. Really anything to do with enucleation, anything to do with BPH surgery, it would be my pleasure. So these are sort of the things I was asked to present on, and I tried to cover all of the topics. So we're going to start with anatomical endoscopic enucleation of the prostate, replacing TERP. We'll talk about the difference between the thulium fiber laser, which is the newest laser really, and the holmium YAG laser. We'll then go more into depth with the SOLEP, or Soltive thulium fiber laser enucleation of the prostate. So indications, equipment, and then technique, advantages and nuances, and then finish off with pitfalls and learning curve, and how you can get started with this new laser. So, you know, it was a very nice introduction, right? We talk about TURP, and we talk about bipolar TURP. This is obviously still being done. This is still the main surgery being done in the world. However, there's been significant evolution. We've obviously got many options now for our patients. Enucleation is, in my opinion, is the gold standard for the surgery for every patient. However, it checks a lot of the boxes, right? It allows for many advantages for patients, but again, it doesn't check all the boxes. For example, just a very simple example is a patient who wants to maintain antegrade ejaculation. After enucleation, majority of patients will not have any more ejaculation. Erections will be okay, the same as before, orgasm the same, but no ejaculation. So if some people really want ejaculation, then this is not the treatment for them. However, the nice thing about enucleation, it's one of the most studied surgical options for BPH. We have a ton of level 1 evidence. We have long-term follow-up up to 18 years. The reintervention rate is about 1 in 1,000. I've been doing this for 12 years. I've only reoperated 1 patient. It provides tissue for pathology. So all of the tissue that we remove, which is about 80% of the prostate, the entire transitional zone, is analyzed, and you can look and see if there's any cancer. You know, we just looked at our data, and in patients who, you know, have been worked up for an elevated PSA, they've had MRIs, they've had biopsies, even when all that is negative, we do enucleation. 8 to 10% of the time, we find cancer. Most of the time, it's low grade. These are obviously oftentimes older men. However, we do find Gleason 7s, Gleason 8s. You know, some of these patients go on to radiation therapy, you know, robotic radical prostatectomy. So this is important information, and this is a nice feature of enucleation. And of course, safety. It has been shown to be extremely safe, very cost effective. You know, the laser fiber is reusable, the morcellator blades are reusable. You know, everything's reusable. So, you know, it's a cost effective treatment, and you don't have to redo it. It can be performed in the patients who are anticoagulated, and it's prostate size independent. You could do a 30-gram prostate, just like you can do a 300-gram prostate. Enucleation, the gold standard for enucleation is HOLEP, right? That's what it was described by Dr. Gilling in the early mid-90s. That's what most people use, the holmium YAG laser, which is a great laser. I used that for 10 years of my career. You can use basically any energy source. You can use bipolar plasma kinetic enucleation or energy. You can do thulium YAG enucleation of the prostate. This is not the same thing as thulium fiber laser, diode laser enucleation, green light laser enucleation, and now we have thulium fiber laser enucleation of the prostate. There are some drawbacks of enucleation. First is length of the procedure, and the second is learning curve. These are two things that people always bring up when you talk about enucleation. So length of the procedure often is said to be a drawback of the procedure. It takes too long to perform an enucleation. However, if you look at the amount of tissue resected per minute, it's actually identical to TURP. The difference is that with enucleation, we remove much more tissue. And this is demonstrated by the drop in PSA, which is about 70% with enucleation and about 40% if you're really good at TURP, maybe 45% drop in PSA. And then learning curve. There is a learning curve for enucleation. If you've never done enucleation, it's anywhere between 20 and 30 cases, but this really depends on how you're learning it. Are you learning it on your own? Are you, do you have a mentor? Is someone teaching you? Is this during fellowship? There's a lot of factors to consider when we talk about learning curve. But the truth is that if enucleation was taught during residency, just like TURP is taught during residency, this learning curve wouldn't be much of an issue. And thankfully, enucleation has really caught on over the last 5 to 10 years. It's becoming very interesting for patients, for urologists, and I think one of the main factors is these new lasers, right? We have all these new lasers, so industry is now interested. So all of this makes for a really nice time to be trying to learn enucleation. So thulium fiber laser, Soltive thulium fiber laser, what is the difference between this laser and the Holmium YAG laser? These are two completely different lasers. So the Holmium YAG laser, which I believe most of you have used, this is a laser that uses a flash lamp that will basically emit photons to activate holmium ions on a crystal. These holmium ions are then sent through a number of mirrors and then into the surgical fiber, and then you use it in the patient. If you want a high-powered laser, you need a number of these cavities, these holmium laser cavities. So you need a number of these flash lamps. Now, the problem is that with these flash lamps, you create a lot of heat. And so you need a cooling system. And that's why your Holmium YAG laser is so big. And that's why your Holmium YAG laser is so loud. This used to be something that they used to say when I purchased my thulium fiber laser, they told me, oh, it's going to be much quieter. I thought, man, what's the big deal? It's a huge deal. It is a big deal. When I'm using my thulium fiber laser, if ever I ask for my Holmium YAG laser, my nurses, they get so upset because it's really loud. The Soltive thulium fiber laser is much quieter, and it's really nice, and it's much smaller too. So thulium fiber laser, this has a long thulium fiber. It's dotted with thulium ions, and these are activated by diode lasers. So very, very different laser. And there's no mirrors, so no cooling is required. And because it has no mirrors, it's much more stable. It doesn't break as much as the Holmium YAG laser. I mean, it never breaks, basically. And the output, the laser that comes out of it, is always the same every time. There's data to suggest now that the Holmium YAG laser, when you put it at 40 watts, for example, you don't actually get 40 watts. With the thulium fiber laser, you always get what you're supposed to get. So two very, very different lasers. Other differences is the settings. So with thulium fiber laser, the energy settings can be much lower. This is mainly needed for stone breakage and dusting. Frequency, obviously, you can go higher with the frequency with the thulium fiber laser compared to the Holmium YAG laser. But again, this is more for stone dusting. This is interesting and very important, and that's the pulse width. So the pulse width on a Holmium YAG laser, so the original Holmium YAG laser is about 350 microseconds. That's for a short pulse. Long pulse, you get up to about 1,300. The thulium fiber laser, its shortest pulse is actually already longer than the Holmium YAG laser. You don't usually have to use more than that. Short pulse is usually enough. However, for hemostasis, I like to use the long pulse, and we'll talk about that when I get to the settings. Depth of penetration. So the Holmium YAG laser, as you all know, has a very shallow depth of penetration, 0.4 millimeters. The thulium fiber laser has an even shallower depth of penetration. And then finally, the wavelength. So the wavelength is very similar between the Holmium YAG laser and the thulium fiber laser. However, the Soltive thulium fiber laser is actually at the peak of absorption in water. So it's actually absorbed 4 times more than the Holmium YAG laser. And this is important for a number of factors. One, for stone disease, because there's water in the stone, so it helps break the stones, but also it's also important for hemostasis. The hemostasis with the Soltive thulium fiber laser is better than with the Holmium YAG laser. And this is for sure. And the reason for this is multiple. One is it has a longer pulse width. It has a shallower depth of penetration. It's absorbed better in water, and it has a lower peak power. All of this makes for better hemostasis. We think these are hypotheses, but I can tell you, and many people will confirm this, the hemostasis is better for many different surgical procedures. So not just for enucleation, but also for stone disease, upper tract TCC. If you want to incise a stricture, it's much, much better in terms of hemostasis than the Holmium YAG laser. Okay, moving on to indications, equipment, and technique. So just a background, it was mentioned, I did 2 years of fellowship with Dr. Lingeman. Dr. Lingeman does exclusively HOLEP. That's what I learned during my fellowship. I came back to the University of Montreal. I did HOLEP for about 6-7 years, over 1,000 hole-ups. One thing with the Holmium YAG laser, it's great laser. However, it does have a little bit more bleeding. It doesn't bleed enough to transfuse patients, but it is a little bit more bleeding. And where this becomes troublesome is when you morcellate. If you have a little bit of bleeding, morcellation can be a little bit tricky. And so I decided I wanted to try the green light laser because it's better for hemostasis. And so I did do green light I did about 10 to 15 cases, and the hemostasis was better. However, green light, as you know, is a side fire laser, and this makes enucleation difficult. So I went back to the Holmium YAG laser, still searching for something better. And about 3 years ago, I found that with the Soltive thulium fiber laser. And since then, I've done over 200 cases, and I exclusively do now thulium fiber laser enucleation of the prostate. You must know that there is a little bit of a learning curve when you switch from the Holmium YAG laser to the thulium fiber laser. They're not the same laser. You have to learn how the laser works, and I'm hopefully going to show you the differences. After about 50 cases, I found that I've become much faster. I have better hemostasis, and most of my patients are going home same day of the procedure. Indications, so Soltive thulium fiber laser, enucleation of the prostate. The indications are very similar to the Holmium YAG laser, not very similar, identical. So it's basically patients who have bothersome urinary tract symptoms. You can do prostates anywhere between 30 grams all the way up to no limit, really. The largest I've done with this laser is 350 milligrams, cc's or grams. So yeah, up to 350, really no problems. I've done patients who are anticoagulated, so on aspirin, not a problem. I've done on Coumadin and I've done on Plavix. So those are not contraindications. Obviously, I try always to stop the anticoagulation if I can. But if you can't, if the patient has a valve and you have to do it under anticoagulation, that's okay as well. Contraindications, obviously, patient who's unfit for surgery. I do 90-95% of my cases under regional anesthesia, so they're not put under general. You don't need to do that. You can if the patient wants to, but it works great under regional. Patients, obviously, who can be put in dorsal lithotomy position. They can't stop anticoagulation. You can still do it. It's not a contraindication. It's obviously not a treatment for prostate cancer, but I have done patients who are, for example, on active surveillance for prostate cancer in retention with large glands. I will do the enucleation, and then if they have to have radiation afterwards or something else, that's not a problem. And then, of course, again, like I mentioned, if a patient wants to maintain their antegrade ejaculation, enucleation is not a good option. Equipment. So you need a video tower or camera. You need a thulium fiber laser. I personally use the Olympus Soltive thulium fiber laser, 550 micron laser fiber. That's what I use for enucleation. 26 French continuous flow resectoscope sheath with modified inner sheath. So it just has a little small, it's sort of like a laser bridge where you put the laser through. A 30-degree cystoscopic lens, laser fiber stabilizing catheter. So this is what I used when I did HOLEP, because the Holmium YAG laser has a lot of vibration. With the thulium fiber laser, there's much less vibration, so you actually don't need this stabilizing catheter. Long nephroscope is required for morcellation. You need a morcellator, of course. I use the Piranha morcellator, and then you need a catheter at the end of the procedure. Settings, so again, I use a 550 micron laser fiber. For enucleation, I use 1 joule, 60 hertz with the short pulse. And then for hemostasis, so on the other pedal, I use 1 joule, 30 hertz with the long pulse. The long pulse gives you these bubbles at the tip of your laser fiber. And this can be distracting when you're doing enucleation, but I actually like it for hemostasis. So technique, I was asked to talk a little bit about end block. So when the enucleation technique was first developed by Dr. Peter Gilling, he did a 3-lobe technique. So he does a 5 o'clock groove, a 7 o'clock groove, and then a 12 o'clock groove, basically splitting the prostate into 3 portions. This nobody does anymore. We've moved on to the 2-lobe technique. So first you do the apical dissection. You then come over the top of the prostate, then you go into the bladder. You then split the prostate in 2, And then you can do either a 5 o'clock or a 7 o'clock. If there's no median lobe, you can just do a 6 o'clock groove. So basically you cut the prostate in 2 pieces and then you push one and then the other. Now, I've gone away from this. This is what I was taught. This is what I did for almost 10 years. I now do exclusively en bloc. I used to think this was harder, but this is much easier to teach. So basically same thing, you do your apical dissection, you come over the top, then you head towards the bladder. You don't cut the prostate in half. You do your lateral side, your posterior side, and then you push the whole prostate into the bladder. This works well for prostates up to 150 grams. Once you get above 150 grams, you usually have to cut it in 2. So I have to do the 2-lobe technique. I like the en bloc because I think it's easier to teach. I think it's easier to learn, but also if you don't have to cut the prostate in half, there's less bleeding. You're not going into the prostate tissue, into the adenoma, and it also saves time. If you look at the literature, you're saving about 10 minutes of surgical time if you do an en bloc versus a 2-lobe technique. Okay, we're going to get into the steps now with some video. So first step, apical dissection, finding the plane. So this is the key step in enucleation. If you can do these first 2 steps that I'm going to show you, you can do an enucleation because the rest is very easy. So the first step in enucleation is finding the plane of enucleation and then doing the apical dissection. So this is a 130-gram prostate. I like to start, here's the sphincter, which is right there. I like to start just proximal to the verumontanum, about 1 centimeter. And I think this is the easiest place to find the capsule. Now, a couple of things. With this laser, the most important thing to notice is I am not touching the tissue. I am about 0.5 centimeter away from the tissue. The reason I do it, there's the capsule there, by the way. The reason I'm 0.5 centimeter away from the tissue is because I try to avoid the charring. Anybody who starts with this laser, that's the first comment you'll get. It's always charring the tissue. I can't see the planes. Just stay about 0.5 centimeter away from the tissue. So there's the plane right there. If you can't find the plane proximal to the verumontanum, the other place you can find it is where the lateral lobe hits the floor, right there, where the lateral lobe hits the floor of the capsule. That's the other place you can find it. Once you've cut the mucosa, you can then push on the prostate, and there's the capsule again. So these are the 2 spots where you can find the capsule. Once you find the capsule, so on the bottom is the capsule, on the top is the prostate. This is the key step in prostate enucleation, finding the plane of enucleation. If you can do that, you can do an enucleation. Try to memorize what the prostate tissue looks like, versus what capsule looks like, okay? This is really, really important. So now I'm just cutting along the plane between the adenoma above and the prostate tissue below. And that's it. Once you've found the plane, you have to stay on the plane. That's the key thing. Stay on the plane. So we found the plane of enucleation. The next step now is to start doing the apical dissection. So here's the same prostate. We're now going up the side of the prostate. So prostate on the left, capsule on the right. So I'm just cutting the attachments between the adenoma on the left and the capsule on the right. Very, very simple, very easy. The other thing I do is when I start doing the apical dissection, I retract my laser fiber just a little bit, so I have a little bit more room to stay away from the tissue so I don't cause charring again. So just cutting along that line, ever so slowly, just pushing slightly on the prostate and cutting between the prostate and the capsule. It's really, really important to stay on the capsule. And these 2 steps, the finding the plane and doing the apical dissections, you have to take your time. This takes longer. It's normal. The sphincter is right behind us. You have to take your time. Now, I'm not showing you the sphincter adenoma separation just because we don't have too much time, but that's another thing that maybe in an advanced course we need to talk about. But so I'm getting over the top now. So the idea here is trying to get to 12 o'clock. So I found my plane. I've done my apical dissection. I'm now almost over the top. Once I get over the top, I head towards the bladder. I'm staying on that capsule. Really, really important. When you turn the corner here, people have a tendency to turn too early or too late. Too early, you cut into adenoma. Too late, you cut into capsule. But this is really important. You want to just make sure you identify the capsule, and stay on the capsule. Again, tissue on the left, capsule on the right, on top. I'm almost at 12 o'clock. I'm like at 1 o'clock, getting close to 12 o'clock. So I'm over the top now. Once you're over the top, you're going to go proximally. You're going to head towards the bladder. Here it is. So I'm over the top, same case, over the top. And now I'm just going back and forth, heading towards the bladder. Again, really important to stay on the capsule. Don't try to guess where the bladder is. Just the capsule is on top. I'm following the capsule. You continue to do that until you see these perpendicular fibers. These perpendicular fibers are the last attachments of the bladder neck above to the prostate below. Once you see that, you know that on the other side of this tissue here is the bladder. So cut through this, and I'm in the bladder here. So once you're in the bladder, it's really very easy now. It's just, cutting along the capsule, staying on the capsule, but the rest of the procedure is very, very easy. Bladder neck always tends to bleed. Whatever surgical procedure you do for the prostate, bladder neck always bleeds. But two things. One, you want to take your time, but two, look at how good the hemostasis is. Throughout the videos that I show you, there's very little time where I have to do hemostasis. The hemostasis takes care of itself with this laser, and that's the really nice advantage of this laser. It's the hemostasis. There's two ways to do an enucleation. You can either use laser energy, or you can peel the prostate off of the capsule. You're going to see me peel the prostate off of the capsule here, and that's okay. You can do that. However, when you peel the prostate off of the capsule, there's going to be bleeding. If you do laser energy, you take care of the bleeding at the same time. So here you're going to see me peel the prostate off of the capsule right here, but now you have to go back and stop the bleeding. If you use laser energy, then it stops the bleeding at the same time. So it's kind of saves a step. So when I started enucleation, I used to do a lot of peeling with my scope. Now I use a lot more laser energy because it just saves me time. So over the top in the bladder, now the easy part is just doing the lateral. Oh, yes. So here is if you want to do a two-lobe technique. So if you want to split the prostate in two, so you identify your orifice, and now you're going to see me cut the prostate. This is a 5 o'clock groove I'm doing. So this is if you want to do a two-lobe technique. If you want to do a two-lobe technique, you have to do an incision either at 5, 6, or 7 o'clock, just one incision, and then one at 12 o'clock. So here I'm showing you the 5 o'clock groove. So, it takes some time. You have to re-identify that capsule. You're now going through prostate tissue. So again, I actually don't recommend this anymore. I used to recommend it. I don't anymore. It takes more time. There's more bleeding. You have to re-identify the capsule. So I'm basically cutting down, trying to get the capsule. And I mean, it's not difficult, but it's an extra step that you don't need to do if the prostate is not too big. So up to about 150 grams, you should be fine. I actually cheat. I actually even do end block for 200-gram prostates because I'm okay with morcellating in the prostatic fossa. For example, if I do a 200-gram prostate and I can't get it into the bladder, I just morcellate within the prostatic fossa, and it works quite well. So here I'm just trying to get down the capsule. I can maybe, it's fine. It just takes about 5. There's the capsule right there. Once you get close to the capsule, you just push the prostate tissue side to side, and it'll peel right off of the capsule, actually, as you'll see here in a moment. So once you've basically done your 6 o'clock groove, then again, if you want to split the prostate in two, you still have to do your 12 o'clock groove, which is what I'll show you here in a second. So I've matched this up with my first incision that I did around the vira montanum. And I'm just coming in here. There it is. There's the capsule right there with a little bit of bleeding. So once you've done that, you have to cut the prostate in two. So you have to do the anterior commissure. Very similar to what you do in open prostatectomies. You cut that anterior commissure. So here I go back in through the urethra. There's the capsule there. And now I'm just cutting the prostate in two. So very easy to do. And, there's no problems if you want to do a two-lobe technique. But I do think that it's a little bit faster if you don't. Saves you some time and there's a little bit less bleeding. So just cutting the anterior commissure, so nothing too special. And then the last thing is the lateral and posterior enucleation. So basically I go as much as I can laterally. I try to get down to 6 o'clock even. You want to do especially if you're doing an en bloc procedure, you want to do the lateral sides as much as possible, all the way down as much as you can go, because when you're doing an en bloc, it's the lateral portions that are harder to push into the bladder. So you want to do lateral as much as possible, and then you can lift up the prostate and push it up into the bladder. So really not too difficult. This is the part of the procedure where you can go faster because everything's pretty much done. The beginning, the apex, you want to take your time. Finding the plane, you want to take your time. But the rest of the procedure, you can really speed up, especially the lateral and posterior aspects. This is really where you're going to save the time. You'll see I'm less worried about touching the tissue here. It chars a little bit, but at this point, I just want to get the prostate out. So here's where you're going to speed up and get this prostate out and into the bladder. Few things that are nice. This is a laser that has very little burn back. So the Soltive thulium fiber laser, very little burn back. You don't have to strip the fiber. The fiber comes as from the factory, from the company, with only about a centimeter that is stripped. And that's enough. You never have to strip more. With the Hoyum-Yag laser, you always have to have about an inch or so stripped of the fiber, or else you get back to the blue cladding, and then it's less efficient. So once you've done the lateral aspect, then you want to lift up the prostate. You see me lifting it up here, and I'm just going to, basically do the same thing and push it up into the bladder. So advantages and nuances. Really quickly though, before I do that, I didn't talk about morcellation. Old morcellator was the one from Luminous, which was purchased by Boston Scientific. That's a laser. That's a morcellator that you don't want to use. It's quite dangerous. That's what I trained on. That's what I used for the first 5 years of my career. It's a much more dangerous morcellator. The newer morcellators, so you have one from Wolf, the Piranha, you have one from Storz, the drill morcellator, and then you have one from a Chinese company called, can't remember the company, but the morcellator is called the Hawk morcellator. They all work very similar. It's an oscillating morcellator. The older morcellator used to go back and forward, very dangerous for the bladder, but the newer ones are all oscillating. They work great, really fast, and very safe now. So morcellation is not a problem anymore. So what are the advantages and nuances of the Soltive thulium fiber laser? So first thing, I already mentioned this, you want to stay away from the tissue, okay? Very important. So you're going to see two videos here at the bottom. On the left side, the one you see right now, that's early on in my learning curve. The one that you'll see next to it is later on in my learning curve. The big difference is in the first video, the one with all the charring, it's because I was touching the tissue. I didn't understand that you need to stay away from the tissue. Look how far I am on the other video. Look how much nicer the other video looks. I'm away from the tissue. There's less charring. I can see the planes better. The hemostasis is perfect. The tissue separates better. So really important with the thulium fiber lasers to stay away from the tissue. There's no problem with charring. There's no clinical impact of charring, but it can distract you from the planes. So stay away from the tissue. So again, the main advantage of this laser is the hemostasis. At the end of the cases, your prostates or your fossas will look like this. Morcellation is a breeze. And most importantly, I never was able to send patients home the same day of the procedure until I used this laser, because the hemostasis is so good. You want to start slow, like I mentioned, to finish fast. Another really nice advantage, so this is a 2.5 centimeter bladder stone. A really nice advantage of this laser is bladder stones. So oftentimes when you do an enucleation, these big prostates, there's oftentimes a bladder stone. And this laser works great for bladder stones. Here you have, again, a 2.5 centimeter bladder stone. This took 9 minutes. And what I do is I use the exact same equipment as I'm using for my enucleation, the same setup. So I have a continuous flow resectoscope. Laser fiber is the same. It's a 550 micron laser fiber. And I use the exact same settings, 1 joule, 60 hertz, short pulse. And it just blows these stones away. Really, really works well. The other nice thing, I've already mentioned this, but the hemostasis. So every once in a while, you'll hit the bladder. So watch here, I'll hit the bladder mucosa. But the nice thing with this laser is that it doesn't bleed. If you ever use the Holmium YAG laser, when you touch, there it is, I touch the bladder mucosa. If you do it with the Holmium YAG laser, it starts to bleed, right? And then you have to stop and you have to irrigate. But with this laser, there's really no bleeding. It's really an excellent, excellent laser. So like I mentioned, works great for bladder stones. So pitfalls and learning curve. So a few pitfalls, enucleation, it's not the easiest technique to learn. There is a learning curve. I think one of the pitfalls is the do-it-yourself learning technique. I think it's very difficult to just decide on your own to start doing enucleation is difficult. I really think that you need to, first of all, watch videos, watch webinars, speak to somebody who does enucleation, get some tips and tricks about the laser you're about to use. In the ideal world, do a mentorship, go see someone operate in their operating room. And then the ideal scenario is after that, they come to your after that, simulators. So we've done 3 master classes with simulators. There's great simulators now, 3D printed models. They work great. So then after the mentorship, do a master class, use a simulator, and then do a proctorship. Have someone come to your OR and teach you and make sure you know how to do it, and then you'll be flying. Prostate gland size, really important. Small glands are very difficult. Do not start with a small gland. If you're going to do enucleation, start with something between 80 and 120 grams. The small glands, like the 40, 50 grammers, are very challenging. The planes are not well developed, and it is very, very challenging. Morcellator, definitely get one of the newer morcellators. The older one is not fun to use and can be dangerous. If we have time, remind me, I'll tell you a good story about our first morcellator. Thulium fiber laser enucleation of prostate. Holmium versus thulium fiber. This is a question I get all the time. Which one is better? Which one should I use? Let me show you. So first of all, thulium fiber laser, better for hemostasis. That's for sure. There's no doubt. Here's one of the benefits of the Holmium YAG laser compared to the thulium fiber laser. And this is something we get a lot of. One of the big differences between the thulium fiber laser and the Holmium YAG laser is the peak power or the peak pressure. The Holmium YAG laser has a high peak power. Thulium fiber laser has a very low peak power. This low peak power is good for hemostasis, but it's not so good to separate tissue. Now, it might be hard to see in this video, but try to see how the tissue separates. So Holmium YAG laser, because of the high peak power, the tissue separates a little bit better. You see how it kind of pops open when I'm shooting with that laser? Whereas the thulium fiber laser, although it works really, really well, excellent hemostasis, you have to actually cut along the line. It doesn't pop open as much as the Holmium YAG laser. So that's kind of the difference. Thulium fiber laser better for hemostasis. Holmium YAG laser has a bit better separation of tissue. Here's a nice study looking at learning curve. So this is 3 surgeons who had never done enucleation were randomized to learn one of 3 energy sources. So one of them learned Holmium YAG enucleation, one of them used thulium fiber laser enucleation, and one of them did monopolar enucleation of the prostate. So they each did 30 cases. First 5 cases, they watched their mentor do the case. Thereafter, they did 10 cases with the mentor present. And then after that, they basically were on their own. So after 15, they were basically on their own. Prostate gland size is all around 60 grams, very comparable in the 3 groups. But here's the interesting stuff. So the enucleation efficiency, so that's grams of tissue enucleated per minute. At about 15 cases, you can see that it went up significantly with the thulium fiber laser, and that was significantly better than the 2 other energy sources. So possibly, this is only one study, but learning curve might be shorter with the thulium fiber laser. But in all cases, around 15 cases is where you start getting the hang of it. And so that's why I kind of express that, you should go see somebody. That's about 3-4 cases. Then you should have a proctorship, someone come to your OR. That's another 3-4 cases. Then you're getting closer to that 15 case range. Just showing the differences between the 3 groups as they learned the different energy sources. And thulium fiber laser, again, was a little bit faster at about 15 cases. So how do you get started? I mentioned this a couple of times. You want to watch lots of videos, watch webinars, speak to someone who's done it. They have tricks and tips that they can teach you. Mentorship, proctorship, this I think is really key. And the nice thing is that there's more industry support now. So a lot of the companies, Olympus will support you doing mentorships, will support proctorships now. So I'm going to hospitals to teach people how to do enucleation. And this is all supported again by Olympus, by Wolf is doing this, Boston Scientific does this, AMT does this. So a lot of industry support now, which is great. Because before we didn't have any of that. When you start, you want to start with a larger gland. Don't start with those small glands. Something in the 100-gram range or 80-gram range. For those who do other surgical techniques. So if you do bipolar TERP or if you do green light, you should do something that you're comfortable doing with those energy sources. That way, if you run into trouble, you can always switch and do those techniques. The other thing you can do when you start is start by enucleating just a median lobe. So do the 5 o'clock, 7 o'clock groove, just enucleate that median lobe, just to get practice in enucleation, but also practice with the morcellator. And then you can start moving on to the lateral lobes. Try to find a patient without a catheter because that's more inflammatory, and then obviously no infection. So in conclusion, prostate enucleation of the prostate, prostate enucleation, I think, is the gold standard for the surgical management of BPH. There's increasing literature. There's many, many energy sources. We only talked really about holmium YAG and thulium fiber laser, but you can do enucleation with green light. You can do it with thulium YAG. You can do it with diode. All different energy sources. They all have advantages and disadvantages. For me, the main advantage of the thulium fiber laser is hemostasis, versatility. It works great for stone disease, for upper tract upper tract TCC. It works great for stricture disease. And it works really great for prostate enucleation. So with that, again, I want to thank the Asian School of Urology for inviting me to present. It's really been my honor and privilege. Hopefully, I've helped some people convert over to Soltive thulium fiber laser enucleation of prostate. It would be my pleasure to take your questions.
Excellent talk, Dr. Bojani. I've been watching on the how many audience we have, like constantly more than 100, 110. It's really amazing. Yeah,
amazing. On a Saturday morning, that's incredible.
Yeah, people work very hard here.
Wonderful.
So, and there's also tons of questions. So
great.
Looks like there's advocates for different kinds of laser.
Yes.
May I just start with this? I think some of the questions that you actually have already answered them during your talk. So let's start from the definition. So you talk about the thulium laser and also the thulium fiber laser. So there, and also the topic today is actually you kind of call that as SOLAP. So
yes.
Can you kind of go with all these definition and
yes.
what the differences between the so-called the SULAP and the thulium fiber laser lab and the SOLAP?
Yes, excellent question. This is something that becomes very confusing. So The first thulium laser was actually in the early 2000s. It is the thulium YAG laser. This laser is very similar to the holmium YAG laser. It has a very similar wavelength, but it's a continuous laser as opposed to the holmium YAG, which is a pulsed laser. The thulium YAG laser, this is not what we're talking about. The thulium YAG laser is only used for BPH. You can't use it for stone disease. And it causes a lot of charring of the tissue. However, it's excellent for hemostasis. There's a lot of people who use this or have used this for enucleation and for vaporization. So that's an older laser only for BPH, great for hemostasis, but lots of charring. Then you have the thulium fiber laser. This is a completely different laser. You know, this is very, very different than the thulium YAG laser. This is a pulse laser, shorter depth of penetration, wavelength. The inside of the laser is completely different. And this is what we're talking about. So this is thulium fiber laser enucleation of the prostate. Then SOLEP. SOLEP is Soltive thulium fiber laser enucleation of the prostate. So this is thulium fiber laser, the specific laser that comes from Olympus, the Soltive thulium fiber laser from Olympus, which is what I use. And so we've coined the term SOLEP.
Okay, so basically, this is kind of a brand name.
Yes, correct.
Of a specific thulium fiber laser.
Correct.
That's being called SOLEP. So I think it's very important to define this.
Yes.
Otherwise people get confusion.
Yes,
Let
Dr.
me-
Naeem, thank you for that wonderful talk. Quoking from Singapore, and I do HOLEP
Yes.
and I've done a few SOLEPs. And
Yeah.
on the definition of TULEP, can I just check with you in the AUA guidelines when they write the recommendation for patients and for anticoagulants?
Yes.
Is the TULEP referring to the old thulium laser or the
Yeah.
new TULEP?
No, it's you referring to the thulium YAG laser.
Right.
Yeah, the thulium fiber laser is too new. It will be added though, because the hemostasis is the same as the thulium YAG. It's it should be added to the guidelines. I think the next ones. So what I like is that, first of all, obviously you can use it for stone disease, which you can't use for the thulium YAG, but also you get the same hemostasis with less charring. So if you've ever used a thulium YAG, it's great for hemostasis, but there's a lot of charring.
Thanks, Dr. Naeem, for the excellent talk. Very comprehensive as usual. The video makes it look so easy that we beginners would think that it's so easy, but actually it's not. It's not going to look like that, when we try to do it. I'll just take this opportunity to, introduce Dr. Lai, because we haven't had the opportunity to. So Dr. Lai was actually, one of the first urologists in Singapore to perform HOLEP. He had his fellowship trained, probably the only one fellowship trained and accredited urologist in Singapore to perform the procedure. So I would let you take the lead, Dr. Lai, for the questions that the panel has bombarded us with.
Yeah, there's quite a lot of questions, so we'll try to crack through them.
I'll just mention, it looks easy, and it's not, Dr. Lai, it's not that difficult, right? Once you get the hang of it. But what's most important that people need to understand is it is the most funnest surgery that I do, and the most rewarding. And once you get into the capsule and you understand it, it's such an enjoy. It's such a joy to do this surgery. I do percutaneous nephrolithotomy. I do ureteroscopy. I do bladder tumors, and but the funnest surgery by far is enucleation. Dr. Lai, you must agree,
I
right?
totally agree. Yeah, I totally agree. I spent my residency learning TURP, and I thought I wasted so many prostates. Yeah. But a change takes time. So let's crack through some of the questions. We have a question from Dr. Samajit, whom is a urologist at my previous institution, and he does HOLEP because he's probably better than me now because he does en bloc. So he has a few questions because I think he's also interested in doing SOLEP. He says the TFL does not have the explosive effect of the holmium, I think, which you answered. So I think holmium separates the plane easier. So
higher peak
yeah,
power.
so he asked the question, do you have to use more mechanical force to show yourself the plane?
Yeah, that's a great question. So I think that's kind of the tendency when you start with the laser is when I started with the thulium fiber laser, I was touching the tissue, so there was more charring, and they would stick the tissue together, and then I would use manual traction, and I didn't like that at all. So yes, in the beginning, there was more manual traction, but I've gone away from that. As soon as I learned how the laser works, you just have to stay away from the tissue. You don't get the charring. And once you get into that plane, you find it, you just cut along it, and you can use manual traction if you want to, but you don't have to. And I've gone very much away from that now. Rarely, like Holmium, I'll use it if I'm not sure where I am, or I want to confirm, or if sometimes I want to go faster. But usually I do a lot of laser energy, lots and lots of laser energy, less manual traction.
So I think the most important tip that ties in that question, when you show us the videos, are you using the short pulse, 1 joule 60 hertz, or or when you hemostase, you use the 1 joule 30 hertz? Do you alternate the pedals, or do you just stick to one pedal?
Yeah, good question. So I have the left pedal is 1 joule 60 hertz short pulse. The right pedal is 1 joule 30 hertz long pulse. So my right pedal is supposed to be for hemostasis, but I'm telling you, I maybe use the right pedal twice in a case. You know, and Dr. Lai, you use it. I did Holmium. I know you get those bleeders, and they'll stop eventually, but it takes you a while sometimes. And you dig in there, especially near the bladder neck. That doesn't happen with the thulium fiber laser, really. Once in a while you get a little bleeder, and then you have to buzz it, but it's really different. I'm telling you. And so you don't get those big bleeders. It's very rare that I use that other pedal. I use it sometimes, but really just with that 1 in 60, it takes care of the hemostasis. And once in a while, they'll have a little bleeder here and there, but usually it works great with that 1 in 60 short pulse.
So you complete almost the entire surgery using the 1 joule 60 hertz short pulse? Yeah.
Yes.
And do you need to decrease? Do you think there's any role for decreasing the energy near the sphincter?
Such a good question. So I thought so. I thought so. But I don't anymore. I do the sphincter adenoma separation. I wish we had more time. I can show you some videos of that. But I do sphincter adenoma separation, and I used to lower the energy. And I remember I was talking to Professor Gross, and I was saying, "Oh yeah, near the sphincter, I reduce the energy." He's like, "Why do you do that? Stop doing that. We never reduce the energy. Keep going." So now I go 1 in 60 all the way around. I think it works great.
So I think to that question, how do you negate the charring effect? So I think you've already answered that.
Yeah.
But I think that's a very important tip, especially for someone starting on SOLAP. Maybe you
Yes.
can just reiterate on that.
Yes. So I stay about a half a centimeter away from the tissue. When the main time where this becomes difficult is when you can't stay that distance away, right? And that's when you're doing the apex. The apex, you're constrained. There's a less space. So I pull my laser fiber a little bit back. That gives me an extra half a centimeter to be able to be away from the tissue. So the key to getting rid of the charring is just staying away from the tissue, about a half a centimeter or so. Again, there's nothing wrong with charring. It's just distracting, right? And when you're doing enucleation, you want to try to find the planes. You don't want the charring effect. So really in the beginning, especially in your learning curve, stay away from the tissue. But now once I've done the apex, after that I just go as fast as I can, and if I touch the tissue, it's okay.
Right. I'll just do one more question before I pass over to Kelvin to ask a few other questions. Again, this is of interest to me to compete with the MIST. Is it possible to preserve the bladder neck and make antegrade ejaculation possible in enucleation?
So definitely preserving the bladder neck, no problem. I always preserve the bladder neck. And honestly, I don't think the bladder neck has much to do with preserving ejaculation. A lot of literature coming out that the bladder neck is pretty much useless. I preserve it just because I think it's anatomical. It's very easy to preserve, even if you're doing en bloc, not a problem. Unless you're doing really big glands en bloc, like 200, then you have to incise the bladder neck, which I don't do. Now, if you want to preserve antegrade ejaculation, there are techniques to do it. And what they do is they actually preserve the from the bladder neck to the viru. So that's obviously the viru. Some of the tissue around the viru they try to preserve, and then kind of the floor. But even with that, they're preserving maybe 50%, 60%. I have not tried it. I don't have experience with it. I tell patients they will not have ejaculation afterwards. If they want ejaculation, I offer them something else. There's other options, right? I mean, aquablation will give you about 80% chance of, maintaining your antegrade ejaculation all the way up to 150 grams. So if somebody really wants to maintain antegrade ejaculation, and then below 80 grams, there's lots of options. So ITIN, Resume, whatever you want. So for me, if they're really concerned about antegrade ejaculation, and you have to have this discussion with them, don't have this discussion after you've done the surgery. If they really want to maintain antegrade ejaculation, I think I lead them to something else.
Thank you, Dr. Naeem. I'll pass on to Kelvin to take a few questions from you.
Yeah, I think in the interest of time, I'm going to just summarize the common kind of questions that some of the audience has.
Okay.
Basically with regards to stress urinary incontinence and how to preserve the sphincter. And also someone asked what are the incontinence rates at 3 months?
Yeah.
Yeah.
Very good. So this is a very important question. So there's two incontinence. There's the temporary incontinence and then the long-term incontinence. So long-term, let's say 6 to 12 months. This is about 1%. In the literature, anybody who does this, and that makes sense to me. Now, the big issue with enucleation is the temporary incontinence. Now, this will go anywhere from 4 weeks all the way up to about 3 months. This occurs in about 30% of patients, give or take. If you're early on in your learning curve, maybe 40%. If you're getting better, 20%. Why does this occur? Who knows? We don't know. There's so many hypotheses. So first, it's maybe the scopes we use are too big. We're stretching the sphincter. Maybe it's the sphincter adenoma separation, which I do now, and I think it helps. But there's no data to suggest that this is what we should be doing. However, I do think that it helps. Doing the sphincter adenoma separation preserves the sphincter. There's no tearing of the sphincter. So it makes sense. So I think if you're doing a sphincter adenoma separation, that temporary incontinence goes down to about 10 to 15%, but there is still some temporary incontinence. So is it the scope that's too big? Are we, stretching the sphincter out too much? We don't know. We're starting a randomized trial. Basically, we're randomizing patients to doing Kegels exercises, pelvic floor exercises with a physiotherapist preoperatively versus not doing them, and seeing if that might be able to help our patients. My biggest take home is I think we should be doing sphincter adenoma separation. It's not easy to do. Especially anteriorly. The sides is not so bad, but when you get up top anteriorly, that sphincter almost melds in with the adenoma. So it's a little tricky up there, and that's where the injuries occur. So it's a difficult subject, but the important thing is at 3 months, they all do great, less than 1% long-term incontinence, but we need to do better for the temporary incontinence. And I think the way forward for getting rid of the temporary incontinence is pelvic floor exercises and sphincter adenoma separation. But we do need better studies, which we're hoping to try to do.
Excuse me, Kevin, may I add some more question at here? Because I think this incontinence issue is something very important. A lot of doctors and the patients are very concerned about this.
Yes.
So there's a Dr. Lin, a colleague in Taiwan from Chang'an Memorial, and he published a paper with the laser technique, but he intentionally preserved the anterior fibrous stroma. So maybe Dr. Bojani can comment about this. As you just mentioned that, if you try to preserve the continence, then probably you can use the aquablation, in which it actually preserved the anterior stroma because of the mechanism just kind of fan-shaped thin. So what's your thought about this? Because with your technique, you went from the apex into the blade through the separation of the prostate adenoma and the capsule through that anterior stroma. So that's kind of the interesting thing to discuss about. Sorry to interrupt.
Yeah. So again, that anterior stroma is very important. How to deal with it is extremely important. So what I've been doing for the last year is when I come around, I didn't show you the video, but when I come around, I actually cut into the prostate to preserve as much as I can the anterior stroma, the sphincter, make sure I don't touch the sphincter behind me. And I think that's really helping. There's even Professor Herman who actually preserves the entire anterior stroma all the way to the bladder neck. But this is very difficult to do. This is time. It takes a lot of time. It's not easy to do. So I don't think that's the solution. I do think you want to preserve as much as you can, but it's tricky. It's not easy. First of all, it's difficult to learn enucleation, but then learning this is another step. But definitely, I think that point is extremely important, and we'll get better.
So there's another question about Moses versus TFL.
Yeah.
A study on that.
Yeah. So we're currently doing a study comparing thulium fiber laser enucleation of the prostate to Moses or what's it called, MOLEP, Moses holmium laser enucleation of the prostate. We are at 30 patients in each group. We haven't looked at the results in detail, but my feeling is it's going to be very similar. So Moses, if you look at the literature, there's 2 studies that say that it's better for hemostasis than the standard holmium laser. However, if you look at it, both studies were subjective. There was no objective data. It was just they turned on a stopwatch while they did hemostasis, and then they stopped the stopwatch. So they said it took a shorter time to do hemostasis, but there wasn't less transfusions. There wasn't less, that's what was shown as the main advantage of the Moses technology, is the hemostasis was quicker, not even better, faster. So I don't know. I haven't tried Moses myself. My colleague here at where I work is doing Moses, and I'm doing the thulium fiber laser. My honest opinion is it's probably going to be very similar. I think all of these energy sources, whether it's thulium fiber laser, green light, holmium, Moses, they all have certain advantages. But I think in the end, you want to do what you feel is best for you. Try different energy sources, speak to people who have used different energy sources, and try to find the best one for you. For me, what I think is most important for me is hemostasis. And the reason that I think it's most important is I teach residents, I teach fellows. And if you start doing enucleation and it starts bleeding, I take away the instruments. So this way, I don't take away the instruments. The student gets to learn more because there's less bleeding. I'm being very honest. So that's one of the main reasons I like this laser, and my students like it too, because they get to keep operating.
I interject now and say that that's absolutely true. I think we do a great enucleation so that our morcellation is the least stressful as possible.
Yes, exactly, 100%.
So
100%.
After we've done enough enucleation, what we're trying to do is just to make the morcellation as less stressful as possible.
Yes.
And therefore,
yes,
I'm still wishing I have a piranha, but I'm using the Stotz drill cut. So there's another question which says, again, it's not an enucleation anymore, but it's on a very important step, which is the morcellation.
Yes.
So it says from Dr. Carl Tan, wonderful presentation. Would you like to ask advantages in doing morcellation within the prostatic fossa, and don't you find it too small? And how about the the rabbit tail or the beach ball effect, whereby a morcellator resistant prostate adenoma?
Yeah, so morcellation super important. I just didn't have time to go into it, but the old morcellator was a back and forth morcellator, very dangerous, but also you always got beach balls. I don't know if you use the luminous one, but they would
I
create
used
these.
it during during my fellowship, but no.
I remember during fellowship, we would be morcellating for hours. I remember with Dr. Lingeman, it was like 10 o'clock at night and we're like morcellating and these beach balls wouldn't break. And it's terrible. With the newer morcellators, you get I used the Storz one, the prototype. So I don't have too much experience with it. But with the Piranha, it's extremely rare that I get beach balls. Very, very rare. It's a fast morcellator, especially if you can see well. I think your point is so important. The hemostasis is most important for the morcellation. Because the hemostasis is so good with this laser, this allows me to morcellate within the prosthetic fossa. Before with the homium, there's a little bit of bleeding. It's not a good idea to morcellate within the prosthetic fossa. But when you see really well, it works great. It is a little bit slower than if you have it in the bladder. So ideally, I want the prostate in the bladder, 100%. But if it's a big prostate, it won't go in. I'm okay morcellating in the fossa until I can push it into the bladder. But yes, definitely, if you get in the bladder, it's better.
May I have one more question? Dr. Bajani, do you find if the patient ever took any 5-hour reductase inhibitor like a finasteride or the dutasteride, do you find it more challenging to find the plane between the adenoma and the capsule?
So the two situations that always comes up for finding the plane is that what you just mentioned, the 5-alpha reductase inhibitors, and then prostate cancer, right? Patients with prostate cancer, you always worry that it goes into the capsule. So for 5-alpha reductase inhibitor, I have not found that. I have not found it difficult. What I have found, however, I thought I found, is that it makes the tissue more dense and makes morcellation more difficult. However, during fellowship, we actually looked at this. So we looked at patients on 5-alpha reductase inhibitors and those without, and it was a negative study. We couldn't prove that the 5-alpha reductase inhibitor increased the time of morcellation. I still find that it makes the tissue a little bit more dense, but I don't think it bothers me for the planes. Prostate cancer, however, can be challenging. I have done many of them, patients on active surveillance who are in retention, large glands. It works well, low-grade prostate cancer. High-grade prostate cancer, 7, 8s, these can be tricky. These can be challenging. You end up having to go into the capsule, and perforating the capsule because enucleation is all or nothing. There's no in between. You have to take out the entire transition zone. So you sometimes have to go into that capsule. So you want to be careful. You don't want to start with those cases. They can be trickier. Wait till you have a little bit more experience.
Thank you.
Yeah, I think it's pretty late. I know Dr. Bojani has very kindly joined us. It's 11 plus at in Montreal now. Dr. Lai, do you have any more questions? If not, I have probably one last question.
I'll leave you to I think it's in the interest of time. I think that there's burning laser questions all around. That I think the best is there's a lot of interest now. I think there's a lot of fine tips and tricks that you can learn from proctorship and seeing surgeons who do it, because no matter what, it is a skill that you need to learn in the OT, but definitely having webinars like this helps to clarify a lot. So Kelvin, please take the last question.
Thank you. So, most of our centers here may not have started doing enucleation. We are thinking about starting enucleation, and most of us are still doing bipolar TURP, for example. Do you have any advice for these centers? How do we actually start or sell the service? Do you just go up and say, I think it's the new gold standard, although there's the alternative of TURP, I think you should do, laser enucleation, or how do you go about starting the service, basically?
Yeah, that's a tough question. For one, I think, at a hospital, the group of urologists have to all agree that enucleation is important. Everybody has to buy in and say, you know what, we need to be able to offer enucleation to our patients. I think that's the first step. If you have that, then you need to identify one person. You don't need everybody to learn enucleation. Maybe they can learn it later, but you need one person. You need to focus on one urologist who will go somewhere, who will learn it well, and then bring it back. And you need to focus on them. You need to support that person, maybe, financially, whatever it is. They have to feel comfortable. And then once that one person learns it, after that, it's easy to teach others, very easy. But that one person needs to have the support of the group, and whether that's fellowship, whether that's mentorship, proctorships, really invest in one person to learn enucleation. I think that's the best advice I can give, and it's the best way to have a successful enucleation program.
That's great, and because we've seen some centers, once they switch to laser enucleation, it seems like they never go back to
Yes.
URP. Whether that's
Yeah. Same here. So we've now moved. There's still TERPs being done, bipolar TERPs here. We still have some green light vaporization. We have aquablation. We have a lot of options here, but we're doing a lot of enucleation now. As you'll see.
Very much. Thank you very much. So thank you to our esteemed speaker, Dr. Bujani, really inspired me. And I thank my co-host, Dr. Choi, as well as the moderators, Dr. Lai and Dr. Calvin Chen. So to finish off, I just want to introduce Dr. Michael Wong, who is our director of the ASU and linked in with UAA. And he has some announcements about upcoming events.
Thank you very much, Naeem. Indeed, it's a pleasure to see you. And, I'm really excited because we both have the same boss, James E. Lingerman, even though we are 18 years apart in terms of our fellowship years. But definitely, you have done a great job, and we really enjoyed the time with you. We look forward to more sessions with you, either in Singapore or in other places as well.
Absolutely. It would be my pleasure.
Definitely. And just another thank you, shout out to Olympus for their excellent support all these years, and of course, their excellent support for the coming years as well. I got two quick announcements to make as we close the webinar. The first announcement is, please, all of you tuning in, please, you're most welcome to attend the biggest urological meeting in Asia, and that's UAA, and that's going to be held on the 20th of September to the 1st of October 2023 in Dubai. It's a very exciting congress, and we hope to see all of you turn up and enjoy not just the scientific content, but also the fellowship among the Asian urology community. The last announcement to make is that for all of you who are Asian urological residents, please remember this very important announcement. And that announcement is that the Asian School of Urology has secured free access for all of you to enter and to enjoy the content of BJUI online knowledge. So please, if you are Asian urological resident, you are given free access. If you're not sure how to do it, just write to us, Asian School of Urology under UAA, and we will give you that access. With that, two short announcements, I'd like to thank everyone once again for tuning in, for Naeem, for the excellent talk, and thank you for taking time to share us your expertise and your experience. With that, I wish everyone a wonderful, wonderful weekend. Take care, guys. See you soon. Bye-bye.
Thank you.
Have a good weekend. See you all soon.
Oh, thank you.
Good night.
Good night.
Good night.